Good afternoon again, everyone. Thank you all for being present. We are going to hear, this is the Finance Committee. It is Thursday, January 15th, and it's our first briefing for the year. And we have with us Dr. Andy York, Executive Director of the Prescription Drug Affordability Board. So, Dr. York, it's all yours.
And members of the committee, thank you very much for the opportunity to speak with you today, and we are honored to be the first briefing for the Finance Committee. We wanted to provide just a quick overview of the Prescription Drug Affordability Board for folks that, just to provide a refresher for the committee. We also wanted to provide an update on our cost review study process, and then finally an update on our policy review process and our progress towards upper payment limits. So you'll remember that the board was created in 2019. We are the first in the country, and we're an independent state agency that's dedicated to making prescription drugs more affordable for Marylanders. We have three main workflows that I'll go through shortly. It's a 5-member board, and it's supported by a 26-member stakeholder council. That stakeholder council has expanded to, it was 26 when it was originally produced, but has been updated to 29 members as of July of last year. And its purpose is to protect state residents, state and local government, commercial health plans, healthcare providers, pharmacies, licensed to the state, and other stakeholders within the healthcare system from the high cost of prescription drug products. And the reason I like to go over that purpose word by word for word is because it articulates exactly how the board is thinking about the pharmaceutical supply chain and its mission and how its work is supposed to support Marylanders. We have 5 board members. You will recognize that there's 2 new faces on the board. So our chair, Van Mitchell, has been with us from the beginning. He's appointed by the Senate President and the Speaker of the House. One of our new appointments is Dr. Georges Benjamin, appointed by the Governor's Office. He is a previous Maryland Health Secretary, so you may recognize his name, and also is the head of the American Public Health Association. So he's an exceptionally gifted and exciting addition to the board. Dr. Stephen Rauchauer has been with us for a few years now. He's appointed by the Office of the Senate President. Our next new board member is Dr. Julia Sletko. She's appointed by the Speaker of the House, and she is a well-respected and esteemed health sciences researcher out of the University of Maryland School of Pharmacy. And then we have Dr. Jerry Anderson, who again has been with us, I think, since the beginning, appointed out of the Office of the Attorney General, and again is a nationally renowned expert on drug pricing. I do like to just go through the bios of the board to let you know that we really are lucky in Maryland to have some of the most talented and experienced folks in this field. And we do have a very strong board doing this work. So as I mentioned, we have 3 kind of large buckets of work when we're talking about how we spend our time and our resources. The first is cost reviews. So these are an in-depth study of certain drugs to understand if they cause affordability challenges to the supply chain. And this is articulated in the statute. So this is, again, our process for looking at specific drugs and understanding if they cause affordability challenges. If the board finds that those drug causes affordability challenges, then the board can recommend certain policies, and the one policy that they have the authority to implement is something called upper payment limits. And this is a policy that addresses drugs that cause affordability challenges, and it's implemented through our we described how it was implemented in our upper payment limit action plan that I think we briefed you on last year. And then finally, we can recommend additional policies. We have an annual report that we produce that can summarize different policy issues in the prescription drug supply chain, and then also make specific policy and legislative recommendations. So we like to go over, especially during the briefings, just the general timeline of our work. So again, we were created in 2019. The bill was established in 2019, but the real work didn't really start until 2021 after we had received our funding. So throughout 2020 and 2021, we were kind of building the infrastructure of the board. In 22, we were establishing the process for the cost review studies and then also working through things like our generics report as they were required. Then in 23, we had solidified the process for the cost review studies themselves. Again, a series of different regulations that we needed to implement. In 24, we developed our upper payment limit action plan, which is basically the process and technical details for implementing upper payment limits. And then throughout 23 and 24, we were conducting our cost review studies. And then finally, throughout 2025, we had worked through that final step. And I'll go through the process and the steps shortly. But we went through, we selected the drugs in 24. We're working through the cost review studies throughout 24 and into 25. And then in 25, we started working through kind of the policies that the board can recommend there. And I'll give it an update on where we are in each of the processes a little bit later in the presentation. So again, for our cost review study process, we have basically a 5-step process. The board has about, so there's statutory and regulatory specifications that create a list of about maybe 2,500 NDCs. So probably, in the hundreds of drugs that are eligible for the cost review study process. So then they identify, then from that list, they narrow them down and select the drugs that they actually want to enter into the cost review study process. And I can go over exactly how that works if you're interested. Once the drugs are in the cost review study process, the staff collect data, both through a request for information and then also just through general research and outreach. Then the staff analyzes the data and publishes it in a report that we call our dossiers. Those are the results, and then so that's the cost review study part of the process. And this just kind of shows you the general timeline and the different steps that we've built into that process. In 2024, so the last time we briefed you, we were talking about the policy review process, which is kind of if the board makes a determination that the drug's unaffordable, what do you do about it? We have our policy review process to go through the policies. So I'll go through that in just a moment. The drugs that the board is currently studying, there's 6 drugs that are in the cost review study process right now. There's Farxiga and Jardiance, both of those are diabetes drugs, Ozempic and Trulicity, also diabetes drugs, and then Dupixent and Skyrizi. Those drugs are autoimmune disease drugs. I'll go through the status of each of those in just a moment. Actually, I'll go through it at this point. So in 2025, we created the cost review study, so we implemented the cost review study process, and then based on the upper payment limit action plan that was approved in October of 24, we actually had to create the regulations to create the process for setting upper payment limits. That was done probably like spring of last year. So we took our first official actions on these drugs in our July meeting of 2025. So for Farxiga and Jardiance, the board made their preliminary determination that these drugs cause affordability challenges, and then that then set the process for moving forward on implementing policies. They had, I think, 4 policies that they recommended. They found, in their affordability determination, they found that the drugs had a WAC that increased higher than inflation. They identified that the drugs had a very high gross spend for making up a large percentage of the overall spend for state and local government budgets. And then also they found that the proportion of out-of-pocket costs for patients was disproportionate to what the net cost of the drug is. That's very technical, and I'm happy to get into it, but these were the 3 things that they found. So the policies that they recommended were, 1, a WAC inflation penalty. So they want the staff and potentially a broader group of stakeholders to explore what it would look like to implement a WAC inflation penalty. They wanted us to explore delinking PBM reimbursement from rebates. They also wanted to move forward with a patient navigator program, and I can go through any of these that you're interested in. And then finally, the board did recommend kind of moving forward with the process for setting upper payment limits for Farxiga and Jardiance. So based on that, there is a series of steps, and I'll go through this in just a moment, that they will go through for those drugs. So you'll see I'm bouncing around the slides. On slide 13 now. So as of July this year, we've been working through what we call our policy review process for those 2 drugs, and then they also just made preliminary determinations on the next 2 drugs, Ozempic and Trulicity. And so what we've been doing since July of 25 is information gathering. The staff made their policy recommendations that I just went over a moment ago, and then the final action is probably going to be occurring this spring. So the way this works is staff made their policy recommendations, I think in September, and they were approved by the board. Now we're in the process of posting our framework document for our upper payment limits. The board staff recommended using domestic reference pricing. All the drugs have a existing price in the United States. It's called the CMS Maximum Fair Price. They recommended moving forward that. We're in the process of publishing something called our methodology document, which will be reviewed by the public. And then the final action is the board will approve everything at the end of this process, which then triggers kind of the next step for setting upper payment limits. So just in terms of timelines, we're going through that process this spring. We hope to have all of our cost reviews done probably by the middle of this year. And as you can tell by the way that I just described this process, the board has expressed feedback that this process is kind of over-engineered. So one of the things that we'll be doing this year is that we'll be kind of streamlining this process for the next round of cost review studies. So early this year, we're going to get general feedback from stakeholders on just how do we tighten this process up. And that would be implemented through regulation. So we expect that to happen kind of through the middle of this year. And then we expect the board to be able to select the next round of drugs by the end of this year. So that's a general kind of overview on how we plan to spend our time this year. And eventually, we want to get this to an annual cycle. You'll see that this is a very extensive process as it's designed now. So we are trying to streamline and get to kind of more of an annual process moving forward. So I've given the verbal overview of the process. The last thing I'll end with is we did have 3 recommendations out of our annual report. So I mentioned that we can make recommendations out of our annual report. There were 3 things that we recommended. One, the board has been working for a long time on promoting general market competition in the space. I think the board likes to use market competition whenever possible to be the best way to get affordable drugs. And one space we see opportunity there is through biosimilar competition. Excuse me. The next thing that excuse me. I'm on the wrong side. The next thing they recommend is transparency. So this is another thing that I think we briefed you on before, but one of the biggest challenges we have in the prescription drug space is it's very difficult for folks to actually understand exactly what the net cost of the drug is. We often get asked by our board members, we see this very high gross spend number. They ask if they set an upper payment limit amount at a certain price, are you going to save money? And it's still very difficult for the staff to answer those questions just based on the data that's available. So the board is continuing to do work around trying to collect drugs around transparency. Excuse me, trying to implement policies around transparency that allowed us to collect that information. We also continue to work on patient navigation services. We do want to formalize this. So one of the biggest challenges that we see, this is representative of all of healthcare, but also in the prescription drug space, is that the system is just so complicated that many patients just don't know how to access the resources that are already available. We have served as, we do constituent services and Maryland client services. When folks reach out to us, we basically help them identify how they can get prescription drugs within this system without us having to make any additional policy changes. We're trying to formalize that in a broader program and make that more accessible to Marylanders. So that's something that we hope to have information on moving forward. And then I also mentioned our kind of market competition biosimilar bill that we're considering. The last thing I meant to reference is in the last session, you had a bill that actually originated, I think, in this committee, Senate Bill 357. And that bill expanded our authority around upper payment limits. So right now, our upper payment limits are limited to state and local government. That's going to be things like the employee health plans, any direct purchases by the state, so prisons, hospitals, and then also Medicaid fits within that purview. This bill states that if we successfully implement upper payment limits for at least 2 drugs for at least 1 year, then that authority can be expanded to the full state, i.e. the commercial space. That authority is similar to authority that exists in other states. So Colorado is a state that currently has that authority, and then also I believe Minnesota and Washington have comparable authority. So it'll allow the board to set upper payment limits that could apply to all Marylanders and hopefully be helpful in helping Marylanders afford their drugs. So with that, I know that was a little more free-ranging and freewheeling than I meant for it to be, so I do apologize. With that, I'm happy to answer any questions you have. I guess one final statement again is that we also want to be a resource for you. As you can tell, there's a lot of things happening in the prescription drug space. I wouldn't be surprised if you have a number of bills that come before your committee related to PBMs and plan design and coverage and other issues with pharmaceuticals. We are always here for you and always want to be a resource for you and want to help you in any way that we can. So with that, I'm happy to answer any questions.
I have some questions. Senator Ellis, I saw your light first.
Yeah, thank you, Madam Chair, and thank you, Dr. York, for your presentation. One question first. You mentioned something in your briefing, and I missed what it was. Inflation penalty.
Yeah.
Did you say WAC?
Yes. So
Could you describe that to me, what that is, please?
the reason we didn't put this into our presentation formally is because it is something that needs to be finalized by the board. So there will be final action when they close out these drugs. But in their meeting where they were voting on the policies, that they're at least approving the policies that they want staff to move forward with, they recommended something called a WAC inflation penalty. WAC is the wholesale acquisition cost, which is the equivalent of like an MSRP or like a list price. And basically what they found in their study was that the WAC is going up at a very high rate, substantially faster than inflation. But the net price of the drug is not going up very fast. And it creates very strange distortions of the supply chain that often harm patients. So they want to look for incentives to keep that, to kind of prevent that practice. Basically, the WAC is like the manufacturers increase their list price so they can give larger rebates back to PBMs. And it just creates a number of strange things that we see in the space. So they want to discourage that.
Discourage the wholesale
WAC inflation penalty, wholesale acquisition cost inflation. It's basically,
Instead of that, use what pricing?
This is something that we spend a lot of time talking about. There's probably about a dozen metrics in prescription drug pricing, and all of them are not very good, if not meaningless. So I don't think there is a specific one. What we're trying to prevent is this very specific practice. So everyone, like WAC is one of the nationally accepted things. So I don't think we would transition away from WAC necessarily, but we are trying to reduce the incentive for them to arbitrarily increase the list price just so they can give larger rebates back to the PBMs. Yeah.
Right. Okay, great.
Sorry.
Yeah, thank you for that.
Yep.
I was listening.
Yeah.
Appreciate it. And also, just want to say that on the list of drugs that the board is studying right now, from an outsider view, it seemed like it's all the popular drugs that advertise really hard on television, right? And so is there correlation between those drugs that are pushing hard on televisions and the actions of the board?
It's a good question.
Because there are thousands of drugs out there, right?
Yeah.
So,
I would say we haven't studied that, so I can't say there's a direct correlation, but I think the drugs do reflect, the drugs that were selected by the board do reflect some of the drugs that have the highest prescription drug spend for the commercial market and the state and local government market. And I think in general, the biggest blockbusters have the most advertising. I think that's a fair statement, though we haven't studied that correlation.
I was just wondering.
Yeah.
And finally, one more point, Madam Chair. Okay, sure. So over the last few years, I've attended the National Council of Insurance Legislators Conference. And this past year, we're in Chicago. Maryland's board has been a big topic, being discussed as a model legislation for the association to encourage other states to do. And the debate was very robust, I must say.
Yeah.
And so you mentioned, I think, several states. So you said Maryland was the first to come with this board, which is being pursued as a model legislation. So what other states have picked up? I think you mentioned some states, but are those states that really have a similar board? And could you name those states, please?
Yeah, and you made an important distinction because there's a lot of literature out there that there are things that are called boards, but there's a very specific flavor, and I would say there's probably like 5 or 6 of those. The second one was based in Colorado, and they're actually probably the furthest along. They primarily focus on using upper payment limits, whereas we are trying to look at all the policies that are available to the state. So they have actually already set an upper payment limit for a drug for their entire state in Colorado. I think it's going to be implemented in January 1 of 27, so it hasn't been implemented yet, but they've set that upper payment limit. Some other states that are far along, Oregon has a prescription drug affordability board that is very similar, though I think they still need to like give it the authority to set upper payment limits. Washington is another board that is very similar to what the Maryland Prescription Drug Affordability does. They have the authority to set upper payment limits for the full state, but it's a very, I mean, ours is a long process. They also have a long process for doing that. And then finally, Minnesota, I think, is probably the most recent one. And they, I think, also have the authority to set upper payment limits for the full state, though they're new enough that they're still kind of just getting started. Though there are a number of states that are also considering creating upper.
Great. Thank you, Tom.
Yeah.
Thank you, Madam Chair.
Senator Reedy?
Madam Chair, I'm glad that Senator Ellis asked about WAC because it's an exciting acronym, but I couldn't remember what it was either. I have heard that term, but I didn't quite get it, so thank you. Kind of going on with Senator Ellis's point about the list of drugs that are currently being looked at. So, and excuse my ignorance, but does PDAB look at just the name brand of those drugs, or does it also evaluate the generics that are available and whether they're overpriced or whether that is a factor in why a name brand drug is higher priced because there are generics out there? Is that a factor in the PDAB discussions?
So it's definitely a factor in the discussions. So the way our statute works is we select the drugs based on like the definition of the FDA definition of a drug, which is basically tied back to its application. So like a new drug application. So when we're studying a drug, when it's selected, we map it back to the new drug application, then everything that falls under that falls in there. And then for generics, it's an ANDA. Right now, we're not studying any generics, but they are eligible to be studied. Back in the late 2010s, you saw a lot of substantial, like the Pharma Bro, Martin Skrlecki, but that was like a generics issue that was very unique to generics. We have not looked at those yet. Everything we were looking at now is a name brand drug. But once you, go ahead.
No, go ahead. No.
Once you actually select the drug for the cost review study, one of the key elements in the cost review study is understanding where it is in therapy. So we actually look at the clinical guidelines, understand how this drug compares to other drugs that you would use. And like, for example, we have 4 diabetes drugs on there. The #1 comparison there, the first thing you do is a metformin generic drug, right? So we consider all of that, but a lot of these newer name brand drugs have advantages over these other therapies. So that's just like the conversation that the
So if they have an advantage, then you'd want to evaluate, okay, wait, it's way more than the generic, but there's this factor on the favorable side versus there's not a lot of distinction between this generic and this name brand. So that would be a negative that you'd look at.
Yep.
Okay.
Yep.
Can I ask just about the structure of the meeting? Because you talked about how you've been reaching out to stakeholders.
Yep.
I had an amendment on the bill last year on the floor that didn't pass, but it's really more for a discussion point. There's been some concern that the meetings there's not enough time for participation in the meetings for stakeholders, for members of the public. And by that, I don't mean that they're not open to that you're not open to the public, but that there's just not enough time for the real kind of discussion that's needed. Now, obviously, no, because this committee is the same way. You could get 17 people that want to talk for 30 minutes each, and you can't functionally do that. So can you discuss that a little? Because I want there to be enough time for there to be real, honest feedback, but I also understand you have to have reasonable limits. So
yeah, and right now that's one of the structures of the meeting. Is that it's actually very similar to legislative rules. There's like a time limit for speakers, and we've heard that concern and very much we wanted to be responsive to it. So what we created is we actually have a whole other step in the process that's called information gathering, and we do something called an informational hearing, which basically anyone can sign up and just tell us everything that they want to tell us, and it's like a back and forth conversation. So for each drug that goes into the policy review process, we basically have this format where it's an open line for them to share as much kind of open conversation as they would like. We do find that to be actually a very useful construct, but we do kind of have it in this like specific segment. And then I mentioned, I was going through how involved this process is and how much we want to streamline it. One of the key things we'll be looking at is how to get the best, most efficient, and most meaningful stakeholder feedback, and then particularly patient feedback. So it's something I think we'll look at moving forward. So when we come around with the next version of cost review studies, or the next round of cost review studies, I would expect it to look different than it does now. Not necessarily the meeting structure, that like 90-second time frame, but when we're doing cost reviews, there will be a forum for folks to just come in and talk like as long as they would like. Yeah.
And the last question, and thank you, Madam Chair, would just be what the anticipation, you may have said it if I misunderstood. Is your anticipation that on these 5 drugs in particular, there will be an action taken within the next few months, or?
We try to have them all kind of land on the same timeline, but it is kind of rolling at this point. So the first 2 drugs, Farxiga and Jardiance, those were the first 2 drugs that the board made their preliminary determinations. I would expect those to be done this spring. We want that process closed this spring. The board has indicated that they want this first round to be closed. The 2 drugs, Ozempic and Trulicity, we have a meeting on January 26th, so 1 week from now, a week and a half, where we're going to go through the policies options, and then depending on what the board's policy options are there, it's also probably going to be a spring timeline to close those out. And then we have 2 other drugs that we're still relatively early in the process. We haven't published the dossiers yet. But based on the experience with these ones, we would expect those to be done hopefully sometime this summer would be my guess. Yeah, so we want to have these closed out.
We're going to end up capping the cost?
It's going to be drug by drug. The board will make those determinations. So right now, for Ozempic and for Farxiga and Jardiance, the board wanted the staff to do the work to show what it would look like to set up for payment limits. And ultimately, that doesn't go into effect until they take their final action. So at an upcoming meeting, in that meeting, they were going to approve a cost review study, which is basically our write-up of like everything that happened, the record of what they decided, how they decided it, and then their policy recommendations. For non-UPLs, it's going to be either a resolution or white paper that they basically approve. So that's the WAC inflation penalty that I mentioned, the Navigator program, those kinds of things. Where we don't have direct authority, it's going to be through that type of format. And then for upper payment limits, if they move forward with upper payment limits, that's done through rulemaking. So they'll approve a proposed rule. So in best case scenario, that's all going to kind of happen in one meeting. They approve the report, approve the non-UPL policies, and then also approve the proposed rule. And again, that goes into rulemaking. So then it follows full APA.
Okay.
Yeah.
Thank you very much.
Yep.
Thank you, Madam.
And Senator Hershey.
Thank you, Madam Chair, and Dr. York, thank you again. Looking at your, I guess, a little bit of a flow chart here, the first action on that is the determination on affordability and whether or not it creates an affordability challenge.
Yep.
I remember when the legislation was being adopted that, we were kind of going back and forth on what is quote unquote an affordability challenge. You said both drugs that you have looked at already did meet that affordability challenge. What was the process of determining that again?
So the board reviews the data in the dossier that we provide. So the dossier is basically all the analysis and information that has been collected. And the board evaluates that information. And then what they're trying to do, and this is actually based on the statute, they're trying to identify circumstances that may be causing affordability challenges. So in both of those drugs, they did find these circumstances. So the circumstances is like data indicating that it is causing an affordability challenge. And then that's when it sends us into this flow chart of like understanding the why. So for those 2 drugs, we found again that the MSRP, the WAC, was increasing significantly faster than inflation. So they found that to be an affordability challenge because it has a number of downstream effects that can harm patients in the healthcare system. They also found that they make up a very high proportion of the gross spend. So for a relatively small percentage of patients, it was making up a significant percentage of the overall healthcare budget for state and local governments. And then the last thing is, and this is based on information from the closed session, but basically they found that the out-of-pocket costs were disproportionate to what the net cost of the drug was, i.e. patients are actually paying more for the drug than they think they are. And that's because basically what they're paying is based on the list price, but then after the rebates and the net price, they're actually paying a significant portion of the end cost of the drug. So all those three are the circumstances that they identified, yeah.
So when you're finding out this information and you're looking at, the WAC is increasing faster than inflation, is there a benchmark that you use that you're measuring this against, with respect to other drugs that are out there? I mean,
To other
how do you
drugs,
determine whatever
yes.
number that is actually, whether that's common or it's not common?
So yeah, it's a great question. So it is compared to other drugs. So basically the analysis that's happening is looking at like its place in therapy, its value in care, the number of patients that are covered by that drug, and then is that proportion kind of disproportionate? That's specific to the gross spend, I guess. So there's I would say no specific thresholds, but it is in comparison to other drugs within the class, treating the same disease, comparing to the clinical impact of the drugs. So yeah.
So you are evaluating these drugs against other drugs in their class and their pricing and their WAC and their high gross spend. You're comparing, so you've got a benchmark list of drugs to compare this again. And then, as you're saying, there's a threshold, and if they're over that threshold, then it's deemed to be an affordability challenge?
That's the general analysis. There's not a specific threshold for those drugs, but that is the general analysis. It is what's available to the board is the different drugs that are like in the therapeutic class, basically what we call therapeutic alternatives, drugs that the physician is choosing between this drug or this drug. Like what is the comparison of those two drugs basically? And to your, yes. So they have the clinical information, they have the financial information, and then they kind of
But
evaluate.
is it possible that you could actually see the left side of this flow chart and in given that analysis find out that it doesn't create affordability challenge?
Yes, absolutely, absolutely. I would say yes on that. And then also one thing to note is that this is also not final action. So based on the additional information that's gathered, the board, the final determination is the I mean, this is the hypothetical, but there's no reason that the board couldn't, after they gather this additional information that wasn't available to them in the dossier, say, oh, actually, this drug is or this drug does not cause affordability challenges. It is a kind of a finite list of things that they're looking at in the dossier, and that's part of why we have this information gathering. We're allowed to kind of look at more items. So I would say, I would expect that there are going to be drugs that are studied that are found to not cause affordability challenges. The other thing I would say is the selection process also kind of, the drugs are selected because what they see in the data when they're selecting the drugs indicates that there's an affordability challenge. So it's almost the purpose of the cost review study is to uncover information that isn't available to the board at the front of the end that shows that the drug does not cause affordability challenges. So that is kind of like an important note there, but I would expect that there's going to be drugs that don't cause affordability challenges if they're studied.
And then finally, one of the last things that you mentioned was out-of-pocket costs. That's been, an issue that we've talked about over and over again in committee here and trying to address, again, what is really the biggest, consideration when you look at the cost of prescription drugs. Yes, certainly it might be what insurance companies pay for them, but the real concern that we hear about all the time is what are patients paying and what is their out-of-pocket expenses. And, there's some of us that might say you can get all the way through at the end of this and the patient might not see a penny of savings through the PDAP process, but they could see changes if we gone through the non-UPL policies that we've talked about. What did your analysis tell you about out-of-pocket expenses and the types of programs that insurance company and PBMs are running?
It's a great question. So one of the things to note is, I think I would put it in the UPL bucket and then just like general observations. So to your point on general observations, what we see is that there's a a subset of patients that are always kind of bearing the brunt. Like there's a significant and very important group of patients that are having affordability challenges, and those are the ones that we are trying to serve. But if you look across the entire book of business, you can certainly find patients that are taking a drug and say that they aren't having affordability challenges. So that's kind of the exercise that we're going through, is like trying to find those patients that are having affordability challenges and then trying to help them. And to your point also, I would expect that there are certain policies that are not UPLs that are going to be very helpful to patients. In particular, we're very excited about the Patient Navigator program. We think that that can make a very significant impact on a number of patients' lives like tomorrow. And it's just because they don't know about the resources that are readily available to them. Mm-hmm. Regarding the upper payment limits and how they'll impact out-of-pocket costs, we've had this conversation in that the UPLs for state and local government will likely, the biggest impact they'll have is like reducing taxpayer spend. This is going to be helping the taxpayers. And the reason that's the case is because the employee health, basically what we find is that public sector health plans, like they basically attract their talent by having very good health coverage. So they're often kind of, it's called copay-based coverage. So it's like $5 copay, $10 copay, $25 copay. And it doesn't matter what the drug costs, they're having these flat copays. Where we can really help is in co-insurance. And that's when the patient is paying a percentage of the WAC, that MSRP, that made up number, they're paying 20% of, again, the WAC. And that's where we think that there really can be a change here. If we do upper payment limits, that can really help those patients who are paying a lot in those cases. We don't really see a lot of those in the state and local government at this point. So again, for upper payment limits for state and local government, it's going to have a limited impact. But again, I think it's the nature of plan design for state and local
because
government.
reducing, and this is what we've talked about, reducing taxpayer spend does not necessarily translate into savings to a taxpayer. It just means that the government has to spend less on something,
Fair enough,
but it
yeah.
doesn't mean that they're writing rebate checks back to the taxpayers, right?
I defer to our legislators on how to allocate those resources.
But I mean, but that's why it's important, as
Yeah.
we've been talking about this all the time. What are we really doing to drive down patient costs, the actual patient, their out-of-pocket costs? And I think we are going to wait to see, does the UPL do that? And maybe to your point that it does it through co-insurance.
Yeah.
Again, I think we'd like to see that that's what's happening.
Yeah.
And, hopefully as you're looking at these drugs, maybe you did set these up that we're going to see something that will do that. But that will continue to be the question. How does it truly affect out-of-pocket spend for the patients? So
Great.
Appreciate it. Thanks. Thank you, Madam Chair.
Thank you. I know you have to leave, so, but Senator Lamb?
Thank you, Madam Chair. Thank you, Dr. York, for that presentation. That was helpful to see where the PDAB is now. I wanted to just touch on some, whether or not PBMs can share information, I guess, either with their clients or in this instance, the state of Maryland, to be able to, get a better sense of how much the client is actually paying for a specific drug. And I guess the heart of this is to be able to have some actual basis of information to see if these payment limits are successful in actually capping the price of these drugs. And without knowing the actual price, it's hard to be able to get back at that actual delta there, right? Is there any thought or suggestion to have either a requirement from state law or some type of provision so that the PBMs would be required to share this information with their clients or with the PDAB so that we can actually determine the effectiveness of these price caps using these specific drug prices from the ones that are being considered by the PDAB?
I love that question. It's the number one recommendation out of our report is trying to create a policy that allows for that. There's a number of technical questions that we've been working through for probably the past year on just exactly what that format is. But I think we are very interested in gauging legislators' interest in passing that kind of policy. We're trying to also understand, can the state just ask for it now? But I can just confirm the first thing you said, that this is not standard practice. Even the payers in the state, if they do not, if they are contracting with their PBM, they actually have no idea how much their PBM is paying for the drug, and that information, even if they ask for it, is not provided to them. So, we had a conversation in one of our, I think probably the Farxiga and Jardiance meeting in September, where the board member asked, like, how much does this drug cost? And even after our request for information, we did get a lot of confidential proprietary information that helped us get a better understanding. But at the end of the day, it's still almost impossible for us to say, like, the state employee health plan pays this much for this drug. It's, yeah. So we have ideas and are very interested in trying to move something forward there.
And can you remind me, are the recommendations coming forward soon for this legislative session, or are they coming for the next legislative
That would,
session?
we have something for this legislative session if that's of interest to the legislator. So, yeah.
Okay, so your recommendations will be coming up very soon, I guess.
Yes. Well, yes. Yes.
And potentially this would be one of the recommendations to
So,
come forward from the PDAB, is that?
yes, there's almost two different things. There's the annual report that came out at the end of last year, and we have working documents for this specific issue. Right now, we're just making sure we're on the same page with all of our state partners. It would be a collaborative effort. We obviously we don't regulate this industry, and then also in terms of data collection, there's other agencies that specialize in data collection. So we want to make sure that anything we propose is exactly what the state's looking for. But I think we are hoping to do something this session. So.
Okay. And then last question, this is one that I think we've touched on before. I guess, given all these changes and whatnot, and I'm glad to see that the board is now taking action or considering action for two of these. How do we ensure that patients are actually receiving these cost savings and that these cost savings aren't just, kind of reaped by the carriers themselves?
Yeah. Yeah, insofar as we're helping patients that have plans where what they're paying is contingent on the price of the drug or the amount paid by the drug on the drug. We in the rule can put kind of guardrails in, basically saying, like, you payer will have this additional pot of resources. These need to go back to the patients. In Colorado, I think they basically ask for a report. And there's two ways that it can go. One, it can just like reduce premiums for everyone, or it can go towards the patient. So I think that's something that I think is still an open issue, and I think it's something we can put guardrails on in any rules that we put out. But I think that it is a priority for the board that any savings here goes back to the patients. So.
Okay. All right. Thank you.
Thank you. Senator Washington.
Thank you, Madam Chair. Just going off that last answer that you had, why isn't that one of the recommendations that the board has made about the funds either going to the cost savings either going to everyone holistically or just the patients themselves? Has that not been fully vetted or studied yet?
Actually, what you just mentioned, I don't think we've considered. So that's actually something we can take back. I guess what I meant to say with that is it's going to be addressed through our regulations. So when we implement an upper payment limit, it's basically going to lay out, we're going to propose a rule through regulation that sets the guardrails. When does it apply? What is the amount? Who does it apply to? And then also protections for patients. There's also going to be things around monitoring, things like that.
Yeah, I want to go back to the list because you kind of made you started off saying what they were for, and I just don't want to Google these. So can you give us can you tell us what these are, what drugs? You said one was for autoimmune diseases. Obviously, we all know what Ozempic is. Mm-hmm. Can you give us that full list of what all these do?
Yeah, so the first two drugs are both in the same class. They're they're SGLT2s, and they're both for diabetes with other, but they also have comorbidities. So things like heart disease, also kidney disease. So they're used in a specific patient population within diabetes. The one thing I will say is all these drugs, as far as we've reviewed them, are all very good drugs. Like, we want patients on these drugs. Ozempic and Trulicity, these are kind of interesting. So they're GLP-1s, and as you mentioned, everyone's heard of Ozempic. These are primarily for diabetes. So these two only have the indication for diabetes. So our study was limited to their use in diabetes. However, through the information gathering process, one of the first things that came out to us is they have this huge use, like GLP-1s as a whole, not that necessarily these two drugs, have this very large conversation about obesity. And our purview in our report didn't really get into that, so that's something I think might be something that's interesting moving forward. But we look at them exclusively in their role in diabetes. But for patients that are obese and have diabetes, they're like a very, very good drug. And then Dupixent and Skyrizi are both, they treat drugs that are based on kind of autoimmune dysregulation. Dupixent, interestingly, is also used for asthma. So it's just very interesting because a lot of the doctors that we've talked to, they prescribe it because the patients, their asthma is actually caused by the same comorbidity, the same thing that's like causing their other autoimmune diseases. So it's actually a very interesting and good drug. And then Skyrizi, again, is just for autoimmune diseases. So
Yeah. Seems like you focus on, I mean, let me ask a question. Are these only 6 ones that the board is reviewing currently?
currently, and it's going to be a cycle. I would say just based on the workload that we've had, it's probably like the 4 to 6 range per year is what we can handle with our resources.
4 to 6 drugs per year.
Yeah.
And a lot of these have mostly dealing with diabetes.
Yes, I think indication, actually, I'm not even sure if that was available to the board members. What they're looking at when they pick these drugs is a list of probably like 12 different metrics. So it's usually things like total spend, per patient spend, overall, like it's a number of like spending metrics and different triggers. I can read the regulations to you, but I'm not sure if indication was considered in there. So I think it was more coincidence that they were diabetes than by design.
I just wonder, I mean, I guess I would like to know why all of them are related to diabetes and not a full range of other drugs that
a great
Marylanders
question.
use
Yeah.
here in the state.
Yeah, I think it's probably because, and I like, I'm just speaking off the cuff. I can't like give stats behind this, but I would imagine that diabetes has a disproportionate share of like healthcare spend. So I think there's probably just like, it's a correlation and maybe causation, but like they are related. That diabetes is a major disease state that has a large patient population, high spend of the healthcare system, and it just so happens that those drugs are also the ones that float to the top of the list when you're looking at drugs that kind of flag all these different metrics that we look at.
Are these the drugs that Marylanders use that on a
yes.
consistent basis? I mean,
Yes. So
the number of Marylanders use these diabetes drugs more proportionally than any other drug.
That's a good question. I don't think that so we did look at like different trends for specific utilization, but I think it just is it's a national trend, but we do look at Maryland data and we just align with the national data. But like when we're doing our analysis, all the numbers that we have are based on Maryland patients. But I'm not sure like
Maryland data follows national trends, or you're basing it off of Maryland data, and then that because of that Maryland data, it follows national trends.
So we use Maryland data, and then the question was, does Maryland have different utilization of these drugs than the national trends? And I don't think we necessarily looked at that, but my guess would be we are basically in line. Like I think if you look nationally, if you look at, maybe not Medicare, but like if you look at nationally, you're probably also going to see these drugs kind of pop at the top of the list as top spenders would be my guess.
This is the first list that PDAB?
Yes. Yep.
Okay. How many of these drugs are manufactured here in Maryland?
It's a great question. I'm not sure if any of them are manufactured per se, but some of the manufacturers do have a Maryland presence. I'm trying to think. I think Farxiga in particular, I think AstraZeneca has made some major investments in Maryland. But otherwise, they range in manufacturing location and headquarters location.
Yeah, I just wonder how many. I mean, we have drug companies here that manufacture drugs here, and
Yep.
I wondered how many that I have here. And I'm just, I think you answered. And I wonder if you can give us this last answer to this. And it might have been asked before, but I'm asking just to be safe. Of these drugs, is there a number that you can provide for us of how much Marylanders are spending on these drugs, or how much the Maryland government is spending on these drugs? Like what that number looks like for these right now?
I don't have it off the top of my head, and I should have it off the top of my head, but that is a number that we can make available to you, is like the amount of spend for the state and local government, even for the Maryland state government, and then Maryland as a whole. We can provide those,
Got it.
but it's in the tens of millions for each. So.
Got it. I have a lot. Thank you very much.
The one thing,
Thank you, sir.
if you don't mind me just providing one additional response, you mentioned just the role of manufacturers in Maryland. Our stakeholder council has the Maryland Tech Council on there, and they did present to the stakeholder council specifically on how Maryland can be kind of a welcoming home for a robust biotech sector. So I would say that, in general, the board is very in favor of innovation and access. Like, quite frankly, we want to increase access by increasing affordability. So.
Is that going to be one of your recommendations? to say what incentives, because we do have a biotech sector in Maryland, mostly in Montgomery County.
Yep.
And how do we expand that? I wonder if that's something that, I mean, there's a lot of doctors there, but
We don't have specific recommendations in this report, but it's something that we have definitely been exploring and can come up with formal recommendations if you'd like. Yeah.
Thank you, Senator. Senator Mounts.
Thank you, Madam Chair. Just a quick question. On the Ozempic listing,
Yep.
so is Wegovy not covered?
It's a good question. So yeah, it gets pretty technical. We selected Ozempic specifically, and it's tied to the NDA. So Wegovy was not a part of, even though it's the same molecule, just at a slightly
It's the
different.
exact same thing, right?
Exactly, yes.
It's the exact same drug, just one's for diabetes and the other's for obesity.
You can see how we got hung up in our process, but following the letter of the law, we stuck with the drug that was selected based on NDA, which was Ozempic, and the only indication for that is diabetes. Yeah.
So if you follow this course, you implement something dealing with Ozempic, will it apply to Wegovy also?
No, just Ozempic. Yeah,
But
that's
it's
just how the
exact, but
process
it's the
works now.
exact
Yes.
same drug with the exact same
Correct.
price, the exact same thing.
And you can contrast that to what Medicare did. They actually, so Medicare just negotiated the prices for semaglutide, which is Wegovy and Rybelsus and an Ozempic, and they did it for all three of them, probably for the reasons that you just noted. So
For all three, so I'm sorry, I'm getting educated. I knew about the Ozempic and Wegovy, but what were the other ones?
Rybelsus is like it's a oral version, but it's specific for diabetes. Yeah.
Rybelsus and,
I think that was the last one. Wegovy, Ozempic, and Rybelsus. There might be another one, but those are the primary name brands that are different.
thank you.
But Medicare created a single for all of them, and it applies to all of them. So
You've answered my question. Thanks.
Thank you. Thank you all for your questions. I want to explore a little bit, Dr. York. These are almost all companies that I see heavily advertised on TV. And I don't even watch much TV, but how much do you think the cost of these drugs are because they're spending so much advertising money?
that is a great question. It's something we've done some cursory observations on, and I think we're allowed to consider advertising spend maybe at like a second tier in our process. So we've done a lot of work trying to understand if we can even gather that information. Can you see how much a manufacturer spends on advertising for a specific drug? I will say it's very hard to track down. So if you like go into their filings, they usually put it in like a much broader category, and it's also very difficult to kind of lock it down by drug. I think the only casual observation that I would make is I'm sure they have a return on investment on money that they put into advertising. I'm not sure that it pulls away from resources from other things like research and development. I think manufacturers would say that it does not. You can walk and chew gum, but I think it's, I think that's probably, I'll leave it there.
Anecdotally, I've heard that Skyrizi is like 1/10 of the cost in other countries as compared to what the cost is here in the United States. And I didn't know if that was because other countries don't necessarily allow advertising of drugs, or what could make such a significant difference?
It's a great question. So advertising is only allowed in the United States, and I think maybe New Zealand. So other countries don't have advertising, but I don't think there's I'm not sure if there's a correlation there or a causation. But what I would say, all other countries negotiate on behalf of their entire patient population. That's so the government negotiates with the manufacturers. That's kind of the big difference, and I think we did this in one of our previous sessions. But the big difference in the United States is that we have a number of small entities negotiating with manufacturers, and they are negotiating on behalf of like very small pools of covered lives. Other countries basically pool all their lives together, and the way you get a better deal is you say, I'm going to give you more patients, and you give me a lower cost. So that's kind of how it works in other countries. Yeah.
Good information. Is there a way to prohibit rebates to PBMs?
I think it's being explored. There's a lot of movement in the PBM space. I wouldn't say it's like a prohibition of rebates, but there's something called point of sale discount. Like basically you move them to a point of sale discount. So the patient feels it at the register versus it going back to the payer. So there's a lot of work in that space. It's very hard to untie, though. Like it's such a complicated system, and it's been going this way for so long. It would be very difficult to untie it. But there's a lot of folks that are exploring policies in the PBM space. Yeah.
I agree. It's a very complicated system.
Yeah.
I see Senator Jackson has his light. Senator?
Thanks, Madam Chair. I believe last year when we had a hearing about this board, there was a complaint about the amount of time when there's like a hearing or a comment
Yep.
section. I think it was 90 seconds. Is that still the
For our
case?
meetings, yes. We did develop a new kind of forum, basically, to allow folks to provide extended feedback. Almost not. It's an important tool in the toolbox. I wouldn't say it was in direct response to the feedback we received, but we are very sensitive to making sure that folks are heard and have opportunities to provide feedback. So we do have the informational hearings as part of the policy review process, and then also when we update our sorry, where's it? Okay, we have informational hearings. It's on this side. There we go at the top. And then also when we update the cost review study process, I think this is something we would want to factor moving forward.
So, a factor in terms of extending more time, or
Provide adequate opportunities for stakeholders to provide the feedback that they want to provide. Yeah.
because the complaint was there wasn't enough time to really.
Specific to board meetings, our board meetings, it's like a very specific, has a very specific structure.
So that's something you are
We
looking
can
at, or
we can take it back to the board. It's something, I think it's like a board set rule, so we can take it back to them.
and you'll report back on that.
Absolutely.
Thank you. Thanks, Mike.
Senator, any other questions? Seeing no other questions, Dr. York, we'll let you off the hot seat.
Great, thank you.
Thank you very much for
Happy
your work
session.
and for your testimony. Thank you. I think we see the Office of Financial Regulation here.
They're right outside.
They're right outside? Okay. We'll give them a minute.
Sure, yeah, we'll just like.
Come on up.
If you guys just want to look at me, if I ever advance the slide, then you just look at me.
Okay, Mike. Look at Amy when you want it.
If I haven't advanced your slide, just look at me and I'll advance your slide. Thank you.
Commissioner Salzar, welcome. Welcome to your staff with you, and we appreciate you here to do a briefing on what's happening in the Office of Financial Regulation. So thank you for being here. You want to introduce the rest of your team?
I will. Chair Beidel, thank you. Happy New Year to yourself and the committee members. I am here today with Deputy Commissioner Sprouse, Assistant Commissioner Balogun, and Assistant Commissioner Amy Hennon, and we'll each take a piece of the presentation so you don't spend all your time listening to me talk. But we are pleased to be here today since we are basically the state's subject matter experts on matters involving financial regulation. Today, the financial services industry features a dynamic environment that touches on all of Maryland's businesses and consumers, and it's at the proverbial cutting edge of technology. Digital assets, blockchains, payment apps, loan apps, AI, all those and traditional consumer financial related businesses fall one way or another under the OFR's purview. So, as I said, we license and regulate and supervise financial service providers. Let me just give you a little bit of background, if you don't mind, just to kind of put you in the right mindset here. We're a small office with a large impact for protecting Maryland consumers, while at the same time striving to ensure that the financial marketplace operates fairly and efficiently, and it's open to new businesses. I do want to encourage all the members of the committee to read our annual reports and the report of the Student Loan Ombudsman so you can read about the success of the Access to Banking Act, where we implemented it, awarding $166,000 in fee credits to our local institutions for maintaining branches in low to moderate income communities. We've made an investment in an important cybersecurity tool, making that available to our institutions to help them protect themselves and their customers. And you can read about how we leverage our strength cooperating with other states throughout the country to enforce and license about 18,000 companies. And also this year, the Student Loan Ombudsman's Office, Assistant Commissioner Hennon, handled over 700 complaints and inquiries. So we're happy to be here. We're happy to help you, all the members, and your constituents with any complaints they may have. We do that with 98 authorized positions and 98% of a budget that is specially funded. So as you can see, our jurisdiction is split generally between depository institutions, which are, as you can imagine, banks and credit unions, and non-depository institutions. So what we would want the committee to know is the big trends these days are, with respect to depository institutions, consolidation in banking and low levels of de novo activity or new institutions. And then the other areas, basically growth in those areas. And then last but not least, the convergence between the new technology, those areas, and the existing institutions, let's say, traditional banking products. In Maryland, following the the nationwide trend, traditional banking has been on the decline because of consolidation. So as you saw, the number of entities is down on the banking side, but it's up on the other side. So let me go through, and is this, let's make sure I'm got slide 3 here. Very good. Okay, so this is what we'll talk about. We'll talk about digital currencies. You'll hear us talk a little bit about the current status and some things that we believe, some issues that, topics that'll come up during this year's legislative session, staking, again, virtual currency kiosks. There's some issues with national trust charters. Then we'll roll into stable coins. You probably hear about them, artificial intelligence, and earned wage access products. Okay, so let me start out with the digital currencies here. The story for that is continued growth, tremendous growth, I would say, in all different categories. And what's it being used for? Payments. Remittances abroad is where we're talking about remittances. Investments, you've probably seen those. Gaming and AI. At the federal level, the federal government under the current administration is encouraging their use and their integration into the financial services system, and all the federal financial regulators are following suit in those lines. So, Amy? Okay. Congress is also focused on that. So last year, they passed what was known as the Genius Act, and Deputy Commissioner Sprouse will tell you a little bit about that, because that has implications for the state. And that involved establishing the first ever national framework for stablecoins. It included the those digital assets, and then a framework for how the states can interact with the feds. Secondly, they were doing the Clarity Act, which was a market structure bill that was a follow-on to the Genius Act. That was actually supposed to be marked up today, but that was postponed. So we have a lot of action at the federal level, and then of interest to the committee members as well is that the states around the country have been taking action to update their digital currency laws and authorizations for digital currencies. So just recently, Wyoming came out with their digital currency. Theirs is the first in the nation digital currency, the Rough Rider coin. North Dakota has their digital currency, which is not really for general use, it's for interbank payments. And then California, you can see Nebraska, New York, and Connecticut also have X. All right, so the digital currencies, the current status that we want to talk about here is, the dark side, frankly. So the committee ought to be aware of that. I know last year we talked about crypto ATMs. We'll talk a little bit about those again this year, but there's a lot of AI scams, there's fake platforms, there's use of voice impersonation. So, these are problems. There's also a lot of misinformation out there with respect to the Bitcoin scams and what can and can't be done. So if you can go to the next one. And With that, I will turn it over to Assistant Commissioner Baligan, who can talk to us about staking.
Thank you, Commissioner. And as the Commissioner said, it's a pleasure to be here. Thank you all. My first topic will be about staking. OFR anticipates that a bill addressing staking will be introduced into the General Assembly this year. And so today I will provide a general description of what staking is. I will discuss how state regulators and the SEC is approaching this topic. I will also, so what is staking? Generally, staking is the act of pledging crypto to validate transactions on the blockchain. On the blockchain, consumers are selling and buying crypto. They're transferring digital assets from different digital wallets. And so in order for these transactions to be approved, the blockchain operator has to make sure that these transactions are verified and the system is secure. In order to do that, the concept of proof of stake was developed that allows people to do the work of verifying those transactions. And those people are called validators, and they get paid rewards for the work they do to verify those transactions. To participate as validators must pledge a certain amount of crypto. That crypto can be their own crypto, or it can be the crypto owned by consumers. If the work done by the validators is good, then they get paid in the form of rewards. If there's any bad conduct or illegal conduct, then they are penalized, and this is in the form of losing crypto, which is also called slashing. I mentioned that validators can use or stake the crypto of consumers, and when they do that, consumers are authorizing the validators to use the crypto. The validators are pooling the crypto of different consumers, and at the time of it being staked, those assets are locked. So similar to a bank CD, if you get a 5-year CD, generally you don't have access to those funds in those 5 years. In the crypto space with staking, in that lockup period, the consumers don't have access to those funds. If the validator's work is good, they get paid, and a portion of those rewards get distributed to the consumers, again, similar to a CD where there's interest that is built on the CD and the consumer has access to after that allotted period of time. When we look at how different regulators, states, and the federal government is treating staking, we see that the rules are in flux. They're developing. In Maryland, staking is permitted. However, in 2023, the Maryland Attorney General's office, through the Securities Division, determined that staking is a securities offering. And so anyone who wants to engage in staking must be registered under the applicable Maryland securities laws. And we've seen other states restrict staking for similar reasons. On the federal level, the SEC's current position is that staking is not covered by federal securities laws, and this is a departure from earlier decisions. What we're seeing is that some states changed their positions to follow the SEC's new position. And some considerations for the legislature as you think about what rules should apply include, should this activity be licensed? How should the model be structured? Should there be limitations on what consumers' funds can be used while the funds are locked and in the custody of the validators? And what type of guidance do we want to issue with respect to the selection identity or the role of the validator? Also, what types of consumer protections and safeguards should apply to this activity? Thank you. Now, I'd like to speak about the virtual currency kiosk and the status of the law. Over the past few years, we've seen virtual currency kiosks throughout the country, including in Maryland. We're also seeing a high level of fraud associated with these kiosks. Fraud concerns brought the issue of virtual currency kiosks to the General Assembly in 2025, and as a result, we have SB 305. This new law is currently in effect and requires generally the operators of these kiosks to be registered, as well as each kiosk machine. There's also daily transaction limits, required disclosures, as well as capped fees. We currently have a proposed reg pending with emergency regs in effect. OFR and law enforcement can use these registrations to track and monitor the fraud. We currently have 6 operators that are registered through our office with a total of 646 kiosks. On the next slide, you'll see a map which shows where these kiosks are located throughout the state. The colored portions represent the companies, the virtual currency kiosk operators, and the gray out areas represent the low, moderate to income census tracts. So the map is laid out by census tracts, and if you look at the gray areas, you'll see that half of the kiosks are located within low to moderate income census tracts. OFR is collecting data through the information that we're receiving from the virtual kiosk operators, as well as public information, and we'll continue to monitor this space.
And also, the link on that slide, which you have, is live, so you can zoom in and out when you need to.
Thank you.
Okay, very good. So now we'll turn to more of the federal issues that kind of impact the state of Maryland. And with that, Deputy Commissioner Sprouse will talk to you a little bit about some of the national aspects of digital currencies, as well as the recently passed Genius Act.
Thank you, Commissioner, and thank you for this opportunity. There is a growing tension between states and the federal government over digital currency integration into the national financial system. The OCC has been particularly aggressive in its actions, and it is, in the view of state regulators, impinging on state sovereignty. It's a good example. Its actions to grant national trust charters to digital currency related entities are a good example. Recently, the OCC granted 5 new companies national trust charters for cryptocurrency related activities, and there are concerns about these new companies engaging in banking activities. State legislators should understand that this federal action threatens to take not only trust company businesses from the state's purview, but also to harm local banks if national trusts are given banking powers. The Conference of State Bank Supervisors, known as CSBS, is closely watching events and will take appropriate action. So on the next slide, so what is stablecoin? Stablecoin is a type of digital currency that is growing in exposure and use in the financial payment ecosystem. Briefly, a stablecoin is designed to be stable. Unlike volatile assets like Bitcoin, a stablecoin is typically pegged one-to-one with a stable asset such as the US dollar. It combines the power of blockchain technology with the reliability of traditional money, making it foundational infrastructure for digital payments and decentralized finance. However, certain risks remain, including depegging, which occurs when an underlying asset fails to maintain its intended value. Additionally, the absence of some consumer protections and FDIC insurance present further risks to users. As we move to the next slide, I will highlight how the regulatory framework for stablecoin is being developed. Congress passed the Genius Act in 2025, which created a federal and state pathway for this digital asset to enter the financial system. The law will be effective at the earliest next year, and it creates the federal pathway for entities to use stablecoin in banking and finance. It's quite comprehensive, covering the who, what, when, and how stablecoins can be used. On the next slide, let's discuss the stablecoin regulatory system framework as described in the Genius Act. At a high level, the Act creates a dual system, like in banking, but in this system, states can only regulate entities under $10 billion in assets and share authority with the feds if a state chartered company grows over $10 billion. The key takeaway on the Genius Act is that states can only regulate stablecoin issuers if they have a regulatory framework that is substantially similar to the Genius Act, and they need a qualified state regulatory authority. Maryland needs to act to get in on this system and have a seat at the table for this payment innovation. Thank you.
Okay, thank you so much, Deputy Commissioner Sprouse. Now we're going to turn it over to Assistant Commissioner Hennon, and she'll brief you a little bit on the earned wage access system, which has been happening for a while, as well as finish up with a high level on AI. So, Amy?
Thank you, Commissioner. Good afternoon, everyone. It's a pleasure to be here. The slide before you just has a sort of a lay of the land of what is happening in the earned wage access space. I think the thing that is probably most notable is the pullback of the CFPB, which we have been seeing, including a recent letter in December indicating how they are intending to treat these products. OFR has issued is in the process of issuing regulations that relate to that relate to House Bill 1294 that was passed last year that affirmed these products are loans and required reporting of those lenders. 18 companies have since applied for licenses since the bill passed, or since the bill went into effect, and required reporting will occur in June of 26. HB 1294 did not prevent lenders from asking for tips or prohibit false advertising or ensure that non-discrimination under the Equal Credit Opportunity Act must be adhered to. All other lenders in Maryland must adhere to that.
Okay, I'll turn over the...
And then I think, Deputy Commissioner Sprouse, are you talking about this?
I will.
Oh, you're talking about
I get to talk about it.
Very good.
That's
All
right.
Tell us about AI.
Yeah, unfortunately we had a colleague that was sick, so I get to fill in for her. So I apologize there. So basically, at a high level, our office has been watching AI in the financial service provider field over the past 2 years, and as this continues to evolve every day, of course. So in the first quarter of 2025. Our office sent out a survey to our state banks and credit unions, which provided us some really good detail and information on how they're starting to adopt and use AI in their operations. And in that survey, as of early 2025, 60% of our financial institutions were actively using AI. And then the other 40 that weren't using it, that 30% of that 40 were saying, hey, we're going to use it. It's something that's on the horizon. And the more meetings and the more conferences and the more communications that I've gone to with our financial institutions, I bet you if that survey was done today, we would have a larger number. And our institutions are using that AI to help with operation efficiency and automation, risk management and fraud detection, and customer experience and personalization. And also, in reference to that survey, the survey we did in that first quarter has also been used as a template for the American Association of Residential Mortgage Regulators. So they've used our template to start to do their survey. So the more information we're finding out on AI is helping us as a regulatory body, and then also, of course, gaining an understanding of how our institutions are using it. And the one thing that I will like to say is, like, with our institutions, we are advising them to make sure they are going through and doing their traditional third-party review of like they would do for any vendor to ensure that it would be safe and sound. Some of our concerns on the AI front are the bias, the possible fraud that, of course, that could happen, and also some challenges in employment. And as we continue to watch this and grow with this, we're learning, and we're going to look at how we're going to regulate this going forward.
Okay. Thank you, Commissioner Sprouse. That wraps up our presentation. We wanted to just make some points to touch on. You'll hear about stablecoin. You're obviously hearing about AI. The Genius Act is important, as Mike said, that if the state of Maryland wants to get involved in that, we're going to need a bill. We're working to get a bill in front of the legislature this session so Maryland can partake of that activity as well. And with that, we're happy to answer any questions.
Commissioner, tell me about the bill, because we haven't seen anything here. Is it an administration bill, or is it?
We're looking private sponsor on that. Is that correct? I'll let Amy explain.
Amy?
The private sponsor on the Senate side, I believe, is in this committee.
Okay, just so I mean,
Dun,
that's fine. I just want to make sure. I don't want to miss the opportunity. Has the staking, the sponsor in the House that's working on the staking issue, has she been working with you?
We've had some conversations with them, yes.
Okay, I appreciate that. I think Senator Ellis has some questions.
Thank you, Madam Chair, and thank you for your briefing. Let's first be a little parochial based on my district. Looking at your map where the kiosks are located, I don't see any kiosks in my district, Charles County 28, and very few in southern Maryland. Is that a good thing? I'm thinking not to have them so concentrated there, or what's going on there?
You know what? I honestly, they have been subject to or been used in a lot of fraud. So to the extent they're not there, that's probably a good thing. On the other hand, you know, to the extent you have constituents who want to be involved in the trading of crypto coins, you know, and have it be somewhat convenient, that's a bit of a downside.
Yeah. So why would it, I mean, I'm looking at central Maryland, it's like your map is alive and it's bright, but I mean, is there maybe something the local counties are doing to limit the placement of them? Do they have that
I don't
option?
think so.
Or?
I don't think so. I mean, they are found in typically, you know, convenience stores, gas stations, because I believe they're going to end up having to rent the space or something like that. So it's where they can go. I think that's just a market phenomenon. I'm not aware of any reasons why they're not in areas. I mean, I was surprised there was a bunch in Western Maryland, frankly, and you know, these are the ones we know about. So there may be others that are seeking registration because we're still in the process of finalizing all that.
Is it possible for some kiosks to be there operating that you don't know about?
Yes.
Yeah. Really?
Yeah.
Okay.
Yeah.
Senator, we had a bill last year. I had a bill about the crypto and kiosk and using ATMs, which was confusing people because they thought they were dealing with cash and they were dealing with crypto. But we'll hear more about it this year.
Yeah. Okay. Looking forward to it.
Yeah, and we intend to try to look into that where they, if we find out and they're not registered, we're going to take
So
action.
do you have like, I'm sorry, I didn't mean to interrupt you. Go ahead.
Yeah, I just said we were going to take action to the extent we can identify ones that are unregistered.
Okay, so you will be able to do you have investigators who can drive around, go into these areas that are not being populated on your system to see what's there? Do you actually authorize to do that?
We are authorized. We do not have dedicated people to do that. We have, our enforcement unit would be the folks that would do that, and they handle enforcement of all the laws. So they could go out and do that. Probably as they're out and about, they'll be looking, but right now we don't have plans to specifically send people.
Yeah, because if you have, I mean, if there's a problem you have, well, there's a problem with the kiosk anyway, with fraud. So if they are registered, you know about them, they might have more constraint. So if they're out there doing whatever, not being registered, then it might be even a greater wild south, you know, there in southern Maryland. So I'll follow up with you with that.
Yeah, thank you.
Yeah, thank you for that. And question about the state charter banks that you regulate. Do we have any remaining state chartered banks in Maryland?
Yes, we do. We actually have 19 as of today.
19. Okay, could you name some of them?
Yeah, absolutely, for sure. So we have Eagle Bank.
Eagle, okay.
Right, and
That's
then
our largest.
yeah, that's our largest. We have CFG Bank, which you know the CFG Bank Arena in Baltimore. Woodsboro Bank. We have Chesapeake Bank and Trust. Taylor Bank on the Eastern Shore, which just celebrated 135 years. First United Bank in Oakland, all the way on the Western Shore, just celebrated 125 years. I got to present a governor's citation there, which was amazing to be able to do that. So I can continue to name some.
Okay, well, that's good. Thank you. Yeah, sure. So, yeah, I was just wondering. So, state chartered banks, are they covered by FDIC?
Yes.
Okay. All right. Wonderful. Yes. Okay. Good to know. You know, thank you, Madam Chair.
And they can deal in cannabis. Senator Lamb?
Yeah, thank you, Madam Chair. Good to see all of you again. I know that, I think in the prior session, OFR had presented some information about mortgages. It wasn't part of this presentation, but wanted to just kind of touch on some of this, given kind of the state of our economy, a lot of federal workers kind of in upheaval, and wanted to talk about just foreclosure, I guess, rates and things that are going on. I guess it was brought to my attention because NPR had reported that there were like 700 zombie mortgage foreclosures that occurred potentially in the state of Maryland. Most of these seemingly are in minority communities or majority like Black and brown communities here across the state. So wanted to see from all of you at OFR, have there been specific actions that OFR has taken to address zombie mortgages here in the state of Maryland over the last couple of years?
There was a bill that we put in last year that was intended to address some of the issues related to those mortgage issues. That bill did not get out of the Senate. In addition to sort of the zombie mortgage piece that you're talking about, we are seeing trends of an increase in foreclosure notices, or that initial notice of the missed payments. We are seeing that go up. We are actually actively working with DHCD to do more to notify consumers and borrowers that are experiencing that are potentially facing foreclosure.
And we have been, of course, continuing our regular examinations of mortgage lenders to ensure that there's compliance. To the extent complaints come in on those things, we address them as well. We make sure they're adhering to the law, because don't forget, a zombie mortgage is something where the mortgage has sat for a long time and the lender has not taken any action. Not necessarily illegal, but they have to follow the rules, and we have to make sure they do. And so that's what it is. But as Amy said, we did have a bill in last year that didn't seem to gain traction.
Have you issued any advisory notices for these zombie mortgages, or dispensed any enforcement actions on, trying to address some of the actors behind these zombie mortgages?
There have been some investigations, but they aren't public.
And I guess we can only issue enforcement actions if they violate the law. In terms of the notices, I don't think we've issued anything specifically directed to that.
Any specific relief for like homeowners or mortgage holders in any way?
Well, we can't issue relief. I mean, we can't order somebody to issue relief unless there's grounds for that, right?
I mean, I guess, I was looking at some of these other states, and Massachusetts had taken, I guess, affirmative action to obtain relief for homeowners in that state who had been, preyed upon by zombie mortgages. And so, there were two examples here of like Franklin Credit Mortgage Corporation, also Specialized Loan Servicing LLC. And, wanted to see if here in the state of Maryland, if OFR had taken any similar action against these types of actors.
I believe our office took action against SPS a number of years ago. Franklin does not ring a bell. I'm not sure, but I thought Massachusetts may have been their AG taking action, but I'm not 100% certain on that.
Okay. And then you referenced that you do take some enforcement actions, but I guess not all of them. Are they published on the OFR website when you take enforcement actions?
So cease and desist orders are, but if we enter into some type of memorandum of understanding where they agree to correct a practice, that might not necessarily be in there. Or if we're examining them and we identify issues that just may be resolved as part of the examination process.
Okay, so what goes on the website when it comes to enforcement actions is limited.
It's all our cease and desist orders.
Just the cease and desist orders.
Correct, and some memorandums, but not all.
Okay. You did touch on earned wage access, and wanted to have just a last question here. So since October 1st, when I think HB 1294, as you referenced, took effect, How many EWA providers have been licensed to operate in Maryland? And what is your plan moving forward to be able to monitor these types of providers?
So there are 18 companies that have sought licensure since October, and some of them that had not previously been acting in the state have received licensure. Companies where there was activity prior to October, they are going through our normal licensing process that we would engage in with any lender that had engaged in activity prior to seeking licensure.
And I think we've issued so far 6 licenses or so out of the 18.
I'm not sure what that exact number is today.
Not sure that exact number. But don't forget, that requirement kicked in during the time when we were processing all the other licenses that we do, which is approximately, I think this year, around 18,000 of them. So we are still kind of in that licensing process, and they are part of that flow.
And is there a plan moving forward for OFR to monitor these providers to make sure they're not preying on vulnerable communities or populations and the like?
The bill required reporting by these entities. There are going to be some regulations specifically related to the reporting. The commissioner is going to issue specific information for those companies to report, and the reporting is due in June.
Okay, so there are regs that will stem from
Yes.
Yes.
this. Okay, all right, that's good. Thank you.
Any other questions? Oh, Senator Washington?
Thank you, Madam Chair. Very quickly, just on the enforcement piece, I'm very interested in the Office of Financial Regulation. I know a lot of folks don't know what you guys do.
Yeah.
And looking at this list here, that you guys oversee or regulate: check cashing, consumer reporting, consumer loan lending, mortgage lenders, money transmissions, vehicle loan lending, student loan servicing. It's a lot that you guys do. And I wonder, how many folks are on your team to enforce all these laws and regulations that you, entities that you have to oversee?
So our office is authorized for 98. We have 2 advice counsel. We have 3 enforcement counsel. Our enforcement unit, was that about a dozen folks out of our department? So those are, and so, those are strictly the 3 attorneys. Investigators in the enforcement unit are strictly related to enforcement.
The 3 and the 12.
But then we also have, so we have a consumer response unit where we have certified, typically they've been certified fraud examiners and things like that, that handle consumer complaints. So that's a form of investigation, right? So for example, if we receive a complaint.
How many folks are those?
It's less than a dozen. It's like
Less than a
8,
dozen?
Yeah.
Okay.
So those folks handle it, and then the bulk of the staff is examiners. So we have mortgage examiners, just like we have the bank examination team that's kind of separate for credit unions, trust companies. We have money service business and consumer lending examiners as well. Yeah. We could always use more resources.
Yeah. Where does one find, or do you all publish the amount of violations or complaints that you all receive? Do you publish those on your website?
We have it in our annual report. So if you go in the annual report, you can see the amount of complaints received. Yeah, that's right. It was about 1,000 last year.
How many of those were resolved typically? And how long does it take for those to be resolved?
Yeah, it depends, right? So some of those are, they're mortgage complaints, right? Some of them are auto complaints. They just run the gamut. So it's hard to tell, because if we send a request to an entity saying we've received a complaint, we have to wait for them to respond. If they don't respond, then we have to make a determination, does it go to enforcement? Then enforcement's got to send something out. So, it's hard, you can't put a precise timeline on how that goes.
You kind of can if you wanted to. If you wanted to say, if you've received a violation and you sent the company a violation notice and to fix it or to respond to you, they have a certain amount of time to respond to you, then you get that response. I'm not sure if that's what you're talking about, but I'm just thinking about any.
No, we follow. Yes.
Yeah, and so there is a timeline that you can put with these. And so I wondered if there's a typical timeline to resolve these, because you get 1,000 a year, it sounds like.
Well, we look to get them done 60 to 90 days.
Okay, that's an answer.
Yeah.
That's an answer.
And you know, part of our process is we use a national system, the SES system, which all the states are moving to now. So that's electronic, which has really helped us do that. We're trying to use a lot of electronic tools to get the biggest bang for our buck.
Trying to help you get more pins, man. I'm trying to help you.
All right.
We could use them.
We can use them.
And, you know, it's, you know, part of it, I mean, a lot of folks at home, again, don't know what you guys do. A lot of these cryptocurrency folks, they advertise a lot online to get people in. Does your entity do a lot of advertisement of how to report these things or how to make sure that there's to make complaints?
Yes. So again, we do issue through our outreach team. We have consumer alerts. So if we hear of issues happening in the industry, even if it's another state, we will use it as an opportunity to educate consumers and let them know different trends. We also have been hosting a number of webinars, again, as a way to provide education to consumers and make them aware of the issues going on.
Is that online? Is that in person? Like, how do you guys, I mean, the reason I'm asking this question, I know we can talk about this offline, but I think for the public's sake, it's important because we see these things all the time and we see the trends happen and seniors get affected by these a lot and they don't know who to call. They call Anthony Brown and think he can resolve it. But they really should be calling you guys about some of these to make the enforcement happen. So I wonder, how do you get to a senior? How do I make sure my constituents know that you exist and that they should be contacting you about consumer fraud or any issues like that? I mean, and how do you do it proactively?
Yes, so we would definitely welcome the referrals. We are proactively hosting webinars online. We also have in-person outreach events with our advisories. We do put them on our website, so that's our written, documented information that goes out to consumers. Again, it all depends on how many consumers are coming to our website, but that information and those resources are on our website.
They're not going to your website, but they're not going
And we
to your
partner
website.
with organizations as well.
Yeah.
So
And I wonder, how do you guys advertise around those gray areas that you all mentioned earlier too? We can talk about that offline, but just last question. I didn't see any, I was trying to find in your, I guess there are some recommendations at the end of some of these, but I wondered if you have a list of recommendations for some of these topics that you listed today, that we should be taking some steps in so we can, help you guys do your job well.
Well, we have that crypto bill that the senator will probably talk to you about. We have a earned wage access bill again.
I was confused by the private legislator comment, but I hear what you're saying.
I'm sorry.
Got it. Okay.
A
Go ahead.
sponsor as opposed to a departmental bill.
Correct. Yes. Okay.
So we have that, and I think that's
Other than the Access to Banking Act.
other than the Access to Banking Act, which is kind of a different animal.
Revision.
Yeah, it's a
But
revision.
you will be hearing from us. We'll be filing testimony on bills that we want.
Yeah, I just invite you all to my district and to Prince George's County, where I know a lot of folks need to be informed about what you do and how to contact you, because consumer complaints, I'm not sure how you break them down in your report as far as it comes with counties and what the particular topic is, but I would like to know that too.
Sure, we can give you that. And we've also had quarterly meetings with consumer advocacy groups where in the past I've gone around the state and met with them, with I guess Amy and some of the other commissioners. In terms of the foreclosures, whenever a notice of foreclosure is filed, and that comes to our office, and that is when a consumer falls into default, right? The first step in default process, the lender has to send us a notice saying they're now in default.
Yeah.
We send a letter to the consumer saying you've received, we've been notified, you're in default. Here are the resources. And last year we sent out over 80,000 of those letters.
Oh, wow.
So that's how we make resources known as well.
Okay, thank you.
Yep.
Mr. Vice Chair?
Thank you, Madam Chair. I didn't think I had a question, but I was curious. I know in Baltimore City, the city solicitor and the Office of Civil Rights has opened an investigation as it relates to the fraudulent mortgage scheme, where they were making misuse of the debt service coverage ratio. It's been broadcast in the news that it might lead into like mass foreclosures or whatever. Do you know if you all have been consulted as it relates to that? They're using like the fair housing, which you guys don't enforce fair housing. But I wonder if there's another angle for which you guys have been asked to participate.
Senator, I think I'm going to have to follow up with you afterwards to make sure that we're talking or thinking about the same thing.
Yep, happy to look forward to it. Thank you. Thank you, Madam Chair.
Any other questions? Seeing none. Commissioner, thank you and your team. You're doing a great job. I have really appreciated working with you, and we'll look forward to your legislation this year.
Okay, thank you, Madam Chair. We look forward to working with the committee as well. And again, I want to reiterate, for follow-up or any questions or constituent concerns, send them our way. We're happy to help.
Thank you all for being here. If you're around tonight, there's 2 dinners to choose from.